Okay, Daniel, thank you so much. We are on Facebook right now.
Okay.
I'm going to introduce you to the audience. I'm going to speak in Spanish, Daniel, if you allow me.
Yep.
Bueno, buenas tardes a todos. Gracias por asistir nuevamente a estos webinarios de la Asociación Mexicana en Ultrasonografía Crítica y Urgencias. Estamos verdaderamente muy contentos porque tenemos al doctor Daniel Brainbridge desde Ontario, Canadá. Nos ha hecho el grandísimo honor de estar con nosotros aquí, de compartir su experiencia sobre el tema del ultrasonido point of care en la medicina perioperatoria. Como ustedes pueden ver, él nos hizo el grandísimo honor y el favor de traducir incluso sus diapositivas para todos nosotros. Estamos muy contentos, le agradecemos. El doctor, como ustedes seguramente han leído y han visto artículos de él, pues él es un especialista en anestesia y cuidados críticos y sobre todo se ha enfocado mucho a la parte de la cirugía, la cirugía cardíaca, y él tiene varios estudios sobre el tema muy interesantes, sobre simulación, etcétera, y de hecho él ha recibido varios premios sobre esto. Realmente estamos muy contentos, ojalá que disfruten esta sesión y que puedan interactuar a través de las plataformas. Como ustedes saben, tenemos dos formas de interactuar con el doctor. Tenemos el chat de Facebook y también tenemos la plataforma donde pueden incluso hacer preguntas en tiempo real. Podemos activarles su audio e incluso su video, de tal manera que los que nos están viendo a través de Facebook, bueno, pueden teclear sus preguntas, y los que están en la plataforma pueden activar una función que dice alzar la mano y de esta manera realizar su pregunta, ya sea en forma escrita o en forma verbal, y si quieren hasta pueden activar su audio, de tal manera que hay varias formas de interactuar con el doctor. De verdad, sean ustedes bienvenidos a esta sesión y pues vamos a empezar con algo de lo que el doctor tiene bastante experiencia, que es el ultrasonido en el paciente quirúrgico. Muchas gracias por acompañarnos. Thank you, Daniel. Thank you so much. We really appreciate your presence here. We are honored, Daniel, for accepting this conference. So let's get started with your conference. Thank you so much, Daniel.
Thank you, and I apologize. My Spanish is very poor, so I'm going to be doing this in English. I've done some slide translations for the most part, so that for those of you whose English isn't that good, you can hopefully follow along. What I am going to present today is just sort of a brief talk on the use of ultrasound in the perioperative setting in non-cardiac patients, so those patients not scheduled for cardiac surgery. And I'm just going to discuss the sort of uses for ultrasound. I'm going to show you a couple of cases, and I'm going to go through some of the uses that we've been looking at. Some of it is research, and some of it is what we use on a regular basis. And then I'll wrap it up with a brief discussion about training, where this is all heading. And then I'll leave time at the end. I'll try to talk for about 45 minutes, and I'll leave time at the end for questions. So the objectives, we're going to look at three categories for intraoperative ultrasound. So there's ultrasound in which there's a procedure going on, and that procedure is benefited by having ultrasound available. So renal tumor, for example, in which ultrasound is frequently used. There's cases where you have elective patients which have known problems, so it's patient-related, so poor LV function, congenital heart disease. And then we're going to talk about emergency cases, so patients who have become unstable during the anesthetic or who may arrest during the procedure. We're going to look at some of the differences between TTE versus TEE. People talk about focus or POCUS ultrasound and TTE, but I'll present some images with the use of transesophageal echo, or TEE. Some people refer to it as TOE, T-O-E, if you're from Australia or the UK. And then just again looking at some of the indications and some of the other uses and the common diagnoses that we come across in the perioperative period, and I'll show you some of the research we've done. And this is related to training and what people should know when they are doing ultrasound in the perioperative period. I have nothing to disclose, but this is a picture out my window, and you'll notice the ice on the trees. We're in the middle of an ice storm, so I'm hoping it will not cause problems, but we tend to get power outages occasionally. So this is the image of a poster that we put up in each operating room, asking if people need help with an ultrasound. So we have what is the clinical question, who to page, and we have some common indications: hypotension, problems with left ventricle function, right ventricle function, if you suspect a pericardial effusion. So these are sort of common diagnoses that we should consider doing a POCUS ultrasound on. We have our own program for the residents. So they do a month of POCUS, at which time they're running around with an ultrasound machine, usually the TTE machine, doing ultrasounds on our patients. So I'm going to present 4 cases, and these are just cases. Some of them I've done, but most of them have been done by my colleagues. And I'll show you some echo images, because it's not an echo talk without seeing some echo images. So the first patient was an 87-year-old who was coming for a resection for intestinal ischemia. It was an emergency, and there was a query cardiomyopathy. And the anesthesiologist noticed that post-induction, the blood pressure, systolic pressure fell to 40. So they placed a TEE probe in, and this is the images that they got. And for those of you who aren't familiar with TEE images, that's left atrium, that's right atrium, of course left ventricle, of course right ventricle. And this is what we call the 4-chamber, and this is what we call the 2-chamber. And you'll notice, if you're not familiar with looking at those, that left ventricle was significantly impaired. And what fits with that, if you notice, we call this smoke in the left atrium. You can see this fuzzy, smoky appearance, and that tells you that the flow going through the heart is actually sluggish or slow, which implies a poor LV function. Now, they suspected cardiomyopathy, and that's what was demonstrated in both these views. I would say the ejection fraction is probably 20%, maybe 30%. It doesn't explain entirely the hypotension, but certainly this heart, it isn't empty. It's quite full on both those images. The right ventricle is functioning. There is no tamponade. There's no effusion. This is predominantly LV dysfunction and has to be treated that way. They started inotropes in the patient and vasopressors, in the patient's blood pressure and function improved. Here's the short axis view. So this is what we call a transgastric short axis view. This is the base of the LV. And again, you'll notice there's the mitral valve. This is the inferior wall, the anterior wall, and the right ventricle. And again, you can see an EF, even on that one, maybe 20%. Anterior wall works well, but the rest of it does not. And this is the same image, just as of what we call the mid-papillary view, again, because you see the pap muscles, anterior and inferior, and again, showing poor LV function that needs to be treated. Case 2, this is an interesting case, 38-year-old female who was just coming for an emergency but fairly routine appendectomy. The patient was very large, BMI of 48, was noted to be tachycardic, and was also noted to be a bit dehydrated from nausea and vomiting. Post-induction had hypotension, and so they inserted an arterial line. The blood pressure stayed low, and so they decided to insert a TE probe. And this is what they saw. So again, in the image up here, the left upper image shows a 4-chamber view: left atrium, left ventricle, right ventricle. And you'll notice there's this big mass in the left atrium. And it's actually so large, it actually herniates into the left ventricle during diastole. You see this again from the two-chamber view, showing nicely a large left mass with herniation into the left ventricle. Now, the reason the patient was hypotensive was likely because this mass causes mitral stenosis. And so this patient, if they get tachycardic, are going to have hemodynamic changes that are not good. So the way you would manage this is you would complete the appendectomy as best you could, filling the patient up with volume and trying to slow the rate down. You don't need inotropes here because that left ventricle is working well. It may be a bit underfilled. And then what you need to do is refer them on to have this treated. And this could be a clot, but in this case was a tumor that was just attached to the intraatrial septum. And that's an unusual finding. They didn't suspect this at all. The third case of 4, another female, 53 years old, not quite as large, BMI over only 34. She had a history of smoking and had developed pancreatitis. Before she came to the OR, she was known to have severe hypotension and ischemia of her distal limbs. So in the ICU, critical care, she was intubated, started on fluids and vasopressors. She had a TTE done by cardiology, which showed no clots in her heart. And a CT, though, showed when they were looking for why she had the distal ischemia, actually showed air in the abdomen, free air. So she needed an emergency laparotomy because of the free air. During the laparotomy, they put a TE probe in. And this is just showing you, for those who are not familiar, this is the patient's aorta. This is the descending aorta. And this mass here is not normal, should not be there. If we look at it in long axis, this is what we see. So there's one wall of her aorta, there's the other wall of the aorta, and we have this large mass. And this is actually a clot in the aorta. And the reason she had distal ischemia was because this was throwing off emboli. So the cause of her distal ischemia was now identified. She underwent her laparotomy, but unfortunately did not survive and died several days after the surgery was complete, owing to complications related to this and the subsequent ischemia. The final case is a 45-year-old male who was scheduled to undergo a renal transplant. Was called into hospital because he was a match and was going to get his kidney, his transplanted kidney. On induction, he collapsed, and they were concerned about anaphylaxis. In Canada, all patients who are scheduled to be recipients for any transplant are worked up in terms of their heart and their physical fitness to have surgery. Now, sometimes there's a delay between when they're worked up and when they actually get their transplant. But usually you're pretty assured that the heart works well. However, in this case on TE, this was the picture of this gentleman's heart. You can notice, again, this is a transgastric view. The heart's actually quite dilated from normal. You'll notice how thin that wall is compared to some of the other images we've seen. And you can tell that it's just not working that well. There's some contraction around the ventricle, but there's areas that aren't moving very well, and the whole ventricle is actually fairly dysfunctional. And you'll notice because it's dilated, this can tell you that this has been going on for a while. If it's this dilated and this thinned, it tells you that this isn't an acute event, this is a chronic event. So he's had something for at least several months that has caused him to have significant LV dysfunction. The transplant was actually stopped at this point because of this LV function, and he was returned to the ICU to be woken up, and the kidney was transplanted to someone else. And we stopped doing this because we were unclear that he would tolerate the procedure or not run into more complications afterwards. So these are just 4 cases demonstrating the power of the use of echocardiography in the operating room. These are all done with TEE, and I'll show you some uses for TTE in a minute. But certainly when the patient is asleep, TEE is very handy. So again, there are essentially, I put 3 categories, and there may be a 4th, and I'll discuss the 4th in a minute, but essentially there's procedure related, and I'll talk about one lung anesthesia and the use of point of care ultrasound when someone's having one lung anesthesia. There are cases in which the patient has conditions in which you're concerned. So a patient with a history of poor LV function, congenital heart disease. There's the indications when it's an emergency because the patient has become unstable or because they've actually arrested. And there's the last one I want to consider is whether it's suitable for certain procedures, whether there are certain surgeries for which we should frequently be thinking about doing point of care ultrasound. So the first use of point of care ultrasound I'm going to talk about, and the first one showing TT images, is the use of point of care ultrasound for lung isolation. Now we know frequently that we use bronchoscopy to make sure that we're in the correct position and that we're in either the left or the main bronchus. But we're never actually guaranteed that we actually get lung isolation after we've inflated our cuffs. And one of the ways you can show that you've got lung isolation is actually to use lung ultrasound. And this is just 2 images in a patient who has an isolation of the right lung, so that's not being ventilated, whereas the left lung is. And I'll draw you to, you see probably the more correct image is on the right, so to the left of your screen, because you'll notice we get a rib artifact, and you can see the shadowing coming down here. And that rib artifact is important, and seeing the rib is important because you want to identify the pleura, which is always below the rib. We don't see the rib artifact as well over here, but this is actually from the same patient. So they fortunately, side by side, you get an idea of where the pleura lies, and there's the pleura here. And you can see it dances a bit, but there's no consistent movement of the pleura. So we don't get any shimmering consistently. Whereas here you can see the pleura sliding, and this is the lung sliding that you tend to see. You see it really well there, and then it sort of suddenly stops, and that's just part of the loop. But at the first part of that loop, you see there it goes sliding away. And that tells us that we're ventilating the left lung, and you can see the left lung here and the right RACW there, and that we've nicely isolated the right while we're still ventilating the left. So there have been several studies looking at the use of lung ultrasound for lung isolation, and they've shown that it's very sensitive and very specific. Now, if someone has a pneumothorax, you will appear to have lung isolation, but you won't, because the use of lung sliding originally was designed to identify pneumothorax. So that's one issue in which you may be fooled, but we don't typically have a lot of patients coming who have pneumothorax. So that's usually not a big issue. So gastric volume. So this is just the trials out there looking at the use of ultrasound for gastric volume. I'll show you the 2, this is usually the picture of an empty antrum. It's called the halo sign, where you get this faint signal and a thicker signal in the middle, and that just tells you that the antrum is nicely contracted in an empty stomach, and that's what you're looking for. And this sign is it just shows you a full antrum, and this is done by doing an ultrasound at the midline, and you're trying to identify the liver. and then you're trying to identify the antrum. And classically, if it's empty, it looks like this. If it's full, you get this sort of picture. If it's full of solid, you may get some haziness in here as well, but you won't get a halo. It will be a continuous haziness. People have used formulas, and I've pointed them out here. There are a lot of different formulas what one can use, whether it's children or adults, looking for the quantity of volume and relating that to the risk of aspiration in patients who come. Now, I don't do this a lot in my practice, mainly because the patients that I see who I suspect have a full stomach are all coming for emergency surgery. And so I personally have not found this as useful, but there are some centers that do this fairly frequently and are getting quite facile at being able to image the stomach, looking for the volume of fluids in a patient. So one of the research projects we've done, and that's been recently published in the Canadian Journal of Anesthesia, is looking for patent foramen ovale. So seeing if there's a hole between the atrial septum. And what we do is, and if you're concerned about this, is you can do a bubble study in which you inject agitated saline into the patient's vein. That saline is then pushed into the right heart. And this is a TTE, and I'll run it in a second again. This is the right heart, right atrium, left ventricle. And if you inject bubbles, you should see filling of the right side, but there should be no bubbles going into the left at all. And you'll see these small smattering of bright echo. And these bright echoes are in the left ventricle. And that tells us that there's a shunt. Now, we don't know for sure that it's across the atrial septum, but that's the most common location for a shunt. So in general, that is indicative of an atrial septal defect. Now, why is that important? Well, there's some definitely association in ambulatory individuals who have ASDs, that they're associated with stroke. They're also associated with migraine headaches. But our concern was in the hip and knee arthroplasty patients, whether or not they were associated with a longer stay or potentially delirium in these patients, because we know we have all sorts of debris, emboli, cement that goes into the right side and will either go to the lungs, but if you have a PFO, will cross from the right side into the left and may cause stroke or renal dysfunction. And so this is another use of point-of-care ultrasound that may be beneficial. In this case, the TTE actually has a limited diagnostic value because you're not always going to see these bubbles, even if there's an ASD there. And it's not as sensitive as TEE or indeed other ultrasound modalities. So you just have to be aware of that. But this may be an application of ultrasound in which the procedure, in this case hip or knees, may benefit from a standard, consistent approach for focus. Probably where we're going to get more bang for the buck is looking at fractures. So these are patients who are coming for emergency surgery, and they have not been assessed in terms of their LV function, their RV function, valvular function. And so whether or not focused cardiac ultrasound is going to improve that is of much interest. We're looking at it in our center. This is the center from Australia, from Royce and Canty, and they did a pilot study in 100 patients and found when they randomized them, the 50 patients who got the focus ultrasound, 17 had a change in their management based on the focus. I've done this in my practice. A patient with a fractured hip comes and they have a murmur, and I will then put a focus ultrasound on to see if that murmur is related to aortic stenosis, and if it's not, they'll get a spinal. And if they do have significant aortic stenosis, then I give them a general anesthetic. So that's just an example of how you can modify your approach your plan based on the point of care ultrasound findings. This is our study that's just been funded, and we're just starting on this shortly. We're hoping to look at 350 patients with fractured hips and do a comprehensive pre-surgical focused echo exam and see whether we can show that it has an impact on anesthesia care. So again, this is more based on the procedure that we're looking at, not the actual patient. So if we look at what we tend to find when we look at POCUS, this goes along to training, and so I'm going to switch tacks a bit and talk a bit about training. And we conducted this trial looking as a systematic review in terms of what were the common diagnoses when you actually look at patients who need urgent, emergent, or just preoperative transthoracic and transesophageal echo. We didn't differentiate. So this is preoperative diagnosis, and this is the frequency. So what we found were the two most frequent causes when someone had a concern and looked at POCUS were low ejection fraction, so LV doesn't work, or aortic valve disease. So they've got usually some degree of aortic stenosis. Mitral valve disease was actually fairly common as well at 20%. The rest of them were actually fairly uncommon. So if you're trying to learn point of care ultrasound and you want to figure out what you should know about the LV, low ejection fraction, and learn a bit about the aortic and mitral valve will help you out in about 75% of the cases. Sorry about that. In terms of intraoperative diagnosis, so this is in patients who suddenly have a problem, a blood pressure problem usually, or an arrest. And you can see in this scenario, the diagnoses are quite a bit different. So low EF is in both of them, but in the intraoperative use of POCUS for hypotension or instability, we note that hypovolemia is far more common. That makes up about 1/3 of the cases. Low EF is still there, and that is combined with regional wall motion abnormalities to give you about 2/3 of the cases. So again, if you're trying to just do figure out what you need to learn on your point of care ultrasound that's going to help you the most, those are the three diagnoses that will get you 65% of what you need to know. The other common one was PE. That's difficult to diagnose and involves either seeing the clot or examining RV function. And 17% of all others, so tamponade, pneumothorax, aortic valve disease, mitral valve disease, would all be included in this group. So if you look at them, they're not really the same. So it's important that you actually have an understanding of valve disease if you're going to do ultrasound, especially if you're going to do it as a preoperative assessment. But that actually most of what you need to know is based on how big the LV is and whether it's working or not for the intraoperative diagnosis. And that makes up, as I said, about 2/3 of your diagnoses. So if you're trying to figure out how you're going to do your training and how you're going to teach people point of care ultrasound in the operating room, this is sort of where most of the bread and butter is going to lie in terms of what you should be teaching. So I said I would just talk about this, and this is the sort of differences between the specialties looking for competency. And so there is no real competency that has been specifically defined as a universal standard around the world. And what you have is different bodies making recommendations about what you should know and how much you should do before you know it in terms of your training. I think what most of these programs are going to is a competency-based training program where you have to show that you can be given several images and interpret them, or be given an ultrasound probe and actually collect those images. And so they share that in common, but what images they want you to get, how much you do to be competent, and probably the bigger question is what you have to continue to do to maintain your competence is all up in the air. The February issue of the Canadian Journal of Anesthesia is all on point of care ultrasound. We were invited to provide an article looking at the accuracy and clinical impact of focused perioperative ultrasound. And so that is one of, I believe, 11 other publications in the February issue of the Canadian Journal of Anesthesia, all looking at different aspects of ultrasound, including lung ultrasound, gastric ultrasound, airway ultrasound, and cardiac ultrasound, for which most of us will get most of our work done when we're doing the study. I'll just briefly talk about TEE versus TTE, because there's always a bit of a debate over which is the better approach. Certainly at our center, we use both. TTE, as you know, gives you multiple windows. You can do all of the imaging I talked about, including lung, which TEE is not good at, gastric, which TEE is not good at. It's harder to do images, better imaging in TEE. It's easy on intraoperative patients, whereas TTE not so easy. And you have difficult access during surgery versus easy access. And you can do frequent assessments, where it's very hard to keep popping under the drapes and looking with a TTE probe. So I'm going to sort of wrap this up, and then I will take questions at the end. But these are the big questions I don't think we've answered, and that we need to address. The first one is who. So if you have cardiac anesthesiologists in your center, then maybe they should be doing it. Or should we train specialty anesthesiologists who all they do is POCUS, that's part of what they do? Or should we train every anesthesiologist? So should we expect everyone knows a bit of ultrasound? We have our residents all do 1 month of ultrasound, so we expect them to all know a bit, but I don't think they're all going to be competent in doing ultrasound. The second question is, do we do a complete exam or a limited exam? And what we call a context-specific exam. So cardiac anesthesia, when they started TEE for all the cardiac patients, did a complete exam. Did a complete exam. And the argument is, if you're looking, you should be able to look at everything, and you should be able to come up with a diagnosis if there's something that's not there. The downside to that is it's more training and more chances for making problems. An incorrect diagnosis or missing something. So the training has to be more. And a limited exam, we talk about context specific. So someone has hypotension. So you're looking in the context of hypotension for just a few causes of the hypotension. That is easier to be trained on because there's a fewer diagnoses you're going to have to make. But it's still an issue in terms of missing information, and it's very hard to confine to the context. So although I did point out what was common, there are a lot of uncommon diagnoses that can cause hypotension. And there's a question of whether you should know what those are or whether you should just have access to someone you can refer to. As you notice in one of those cases, having a clot in your aorta is very unusual and may not be diagnosed if you're looking for a context-specific limited exam. And then the other thing is, what should we include? So we talk about cardiac. What about lung? What about stomach? What about airway? And there may be other uses for ultrasound. I had mentioned lung isolation that weren't included in the original studies looking at ICU or emergency, but maybe they should be. And the final one, and it's the same thing with emergency. When you do a focus exam or a fast exam for abdominal trauma, you're looking at fluid in the belly. And some have advocated that anesthesiologists should be competent at doing a fast exam. And others have argued that that's really not important to what we do, and therefore we don't need to know it. And these questions have not been addressed. And I think each country will probably address them independently based on their own practice. So with that, it's been 35 minutes or so, so that should give plenty of time for questions. I'm really happy to take any questions that people have. Thank you very much.
Thank you, Daniel, thank you. Well, I'm going to speak in Spanish for a while.
Yep.
Chicos de la audiencia, ahí me gustaría escucharlos. Hay varios de los que nos están viendo y escuchando que son anestesiólogos. Me gustaría que compartieran su experiencia, sobre todo en cuanto al uso del ultrasonido durante la cirugía. ¿Qué retos tienen aquí en México? ¿A qué obstáculos se han enfrentado cuando están diseñando los programas para anestesiólogos? Que nos platiquen un poco de cómo están los programas para anestesiólogos de ultrasonido, si es que hay o se están trabajando en ellos. Quiero ver aquí en los participantes, tenemos, por ejemplo, déjenme ver, algún anestesiólogo que nos quiera compartir. Mira, voy a permitirle hablar a Rodrigo, creo que es Rodrigo Álvarez, que colabora también con nosotros en nuestra asociación. Y me gustaría escucharte, Rodrigo, sobre cómo tú como anestesiólogo, cuál ha sido tu experiencia en el uso del ultrasonido point of care durante la cirugía, en el perioperatorio. Daniel, I'm going to ask for an anesthesiologist in the audience. Right now, he's listening to this conference, and I would like to hear from him the experience during the perioperative period, how he is using ultrasound, okay? Rodrigo, ¿sí me escuchas?
Sí, sí escucho. Ahí estoy.
Adelante. Ahí estás, perfectamente. Te escuchamos, Rodrigo. Gracias por participar.
Buenas tardes. Lo que nos hemos encontrado básicamente en México en cuanto a programas ha sido muy pobre todavía en cuanto al anestesiólogo. Apenas será un par de años que hay algún programa de point of care en el Congreso Nacional de Anestesiólogos, y lo que te encuentras en la sala muchas veces un poco de renuencia por parte de los equipos tanto quirúrgicos como el mismo anestesiólogo para usar la máquina. Es un poco molesto el campo quirúrgico para poder usar el transductor durante el transoperatorio, pero realmente yo creo que con un poco de entrenamiento, empezar a tomar confianza en las imágenes que podemos ver, adentrarnos más en el corazón, va a ser de mucha utilidad para el transoperatorio. Muchas de la toma de decisiones que se hace durante la cirugía, cuando cae la presión de momento, cuando el paciente se hipertensa, cuando empieza a hacer taquicardia, la toma de decisiones es en base a la experiencia, en base a lo que estás viendo en el campo quirúrgico, pero sería es una herramienta muy útil poder agarrar el transductor, poder ver el corazón, poder ver el movimiento de la pleura, y sobre todo lo que se ha comentado muchas veces en cuanto al uso del ultrasonido. Un escaneo previo serviría mucho para tener esas imágenes ya en tu mente cuando estás haciendo el perioperatorio y un comparativo cuando hay un cambio hemodinámico en el transoperatorio y que pueda hacer un rastreo, tener siempre esa comparación de cómo entró el paciente y cómo se está comportando en ese momento para la toma de decisiones. Creo que es sumamente importante el seguir trabajando, el generar más programas, sobre todo en la medicina perioperatoria, que también es muy pobre en el país. y empezar a darle confianza a los equipos de anestesiología y a los equipos quirúrgicos que vean que es una herramienta que funciona, que vean que es una herramienta que ya es real, que hoy tenemos más en los centros. Ya ahora vas a dar una plática de ultrasonido, visitas un hospital y es una herramienta que puedes encontrar con mucha mayor facilidad. Y bueno, por supuesto, el acceso guiado con ultrasonido, el acceso vascular guiado con ultrasonido, cada vez está tomando más fuerza y creo que hoy ya es obligado que los cirujanos, los anestesiólogos, por supuesto los intensivistas y cualquier otra rama que tenga la necesidad de colocar un acceso central debe estar guiado por ultrasonido. Muchas gracias.
Perfecto, Rodrigo. Muchas gracias a ti. A mí me gustaría también escuchar de parte tuya y en general de todos los que nos están escuchando, cómo se está incorporando el uso del ultrasonido, pero ahora en la evaluación preoperatoria. Yo no sé si hay una escala ya que incluya de riesgo, que incluya las imágenes previo a la cirugía, es decir, que más que basados en el interrogatorio, en la historia, o más bien como un complemento, las imágenes en ese momento, al estar haciendo la evaluación preanestésica, por ejemplo, de estar detectando pacientes con edema pulmonar a través del ultrasonido, o un ecocardio enfocado que permita ver alteraciones inmediatas en el momento de que se está preparando al paciente. Voy a hacer este comentario en inglés para Daniel. Daniel, I don't know if you understood, but I am questioning with our colleague about the using of ultrasound previous to the surgery, Daniel, because there are some scales and preoperative assessment or scales about the risk of the patient during the surgery, but how to integrate the point of care ultrasound in the preoperative assessment. I mean, because as we know, there are other scales, but I don't know if there is a scale or preoperative assessment of risk integrating the point of care ultrasound. Do you have some experience or what is your experience about this?
If you look at a risk scale, there's not a lot that integrates the findings on ultrasound. It's a tough thing to show, though. What I think you're really interested in is whether it's going to affect what you do to the patient. So if you look at most of the research, what it really asks is, if I do an ultrasound, do I then change what I was planning to do? So does it give me enough additional information? The next question then after that is, if I have that information and I change what I do, does the patient do better? And we don't have that information yet. I think what happens, though, is people become so comfortable with ultrasound that they don't want to not use it. So in cardiac today, we wouldn't think twice in Canada. We would be very concerned if we didn't put a TEE probe in, and all our patients get them. And that's just a comfort issue now, although there's a lot of information saying they would benefit. I think what we're at the point of right now for POCUS is finding out where it makes our lives easier. So we're going to do it because it makes our lives easier, or where it improves patient outcome. And I think some of the data based on emergency or arrest is interesting. If you look at the data that's done in the pre-admit clinic, so if you have an elective patient who you see way before surgery, actually ultrasound of the heart doesn't make a big difference. So one of the things that most of us are focusing on is the use in emergency surgery, where the patients are sicker and less likely to benefit, or the use of ultrasound for non-cardiac issues, like identifying lung isolation, gastric volume, pneumothorax, for example.
Okay, thank you so much, Daniel. And when one colleague is questioning, how do you assess, Daniel, during the surgery, how do you assess the volume responsiveness in your patients? This colleague is questioning specifically about the carotid flow, because maybe it is the easier one when we are trying to evaluate in the operating room the volume response. But we would like to hear you about this specific topic. How do you evaluate volume responsiveness? I mean, what is the favorite of you? What is, in your opinion, the better approach in this topic?
So volume is an interesting one because in the ICUs they have the IVC change. You mentioned carotid artery flow, which people have looked at. The part of the problem with carotid artery flow is that we know the brain autoregulates. And so you're also forcing it through an autoregulatory mechanism. So that becomes a bit difficult, but that's been looked at. Volume responsiveness actually is defined as a change in pressure. So if you're going to give volume, we don't even look at the echo. We simply look at the change in pressure. And that's actually the definition of someone who's volume responsive. The question, though, is how can you predict volume responsiveness based on looking at the echo? And I do it very practically. I look at the heart and I ask only one question, and that is it really underfilled? Or does it look normal? Because looking for overfilled is very hard to see. But there's a large number of patients who will have a very small underfilled LV. And when you see that, you know you can give volume. And that's how I assess it on echo. I don't look at flows and I don't look at blood pressures. I do a very gross assessment. And I also try to figure out, is there any other problems? Volume tends to be on my list sort of the last thing. If the LV is working well and the RP is working well and there's no pericardial effusion and they're contracting well, there's no regional wall motion abnormalities, then the hypotension is either due to very low SVR or due to volume. And so then I'm willing to try volume. And that's what I look for. If I can see the heart when it's normally functioning and I get an idea of how big it's supposed to be, the classic one is aortic stenosis, then you can also base on those images. So if you have images where the patient had a normal blood pressure, you can compare it to images where they're hypotensive and see is the LV underfilled or not. You can look at flows through the carotid. You can look at blood pressure changes, but they're all really subject to variability. So it's difficult to tell.
Yeah, okay, thank you so much. Daniel, there is one person questioning about your last slide. He wants to see in detail the last slide when you were explaining about your, maybe this is, or your last article slide, when you were explaining this is the article. Can you explain a little bit more about this article?
Yep. So what we were looking for is how well ultrasound compared to other modalities for diagnosis and how much information was out there based on the clinical impact. So if you're looking at things like diagnosis, it's very accurate for determining things like gastric volume, lung ultrasound, whether you're looking for effusions, for pneumothorax, or for those sorts of pathologies. It's as good and many times far better than doing a chest x-ray. So if you're concerned that you've got a pneumothorax in your intraoperative patient because you've put a central line in, you're far better doing a point of care ultrasound than you are getting a chest x-ray.
Okay.
Clinical impact, there's not a lot of articles out there showing clinical impact. We just don't have enough data right now. I showed you one, and I'll go back up to it. Sorry, a few slides. So this is one of the few that suggested there was a change in management if you did a POCUS, but that didn't necessarily say there was a change in patient outcome. And that's a lot harder to show.
Right.
Does that answer the question, hopefully?
Yes, thank you so much. And well, there is one person, Pavel, si me escuchas ya tienes activado el audio. Si quieres hacer algún comentario, lo puedes hacer ya sea en inglés o en español. Pavel, adelante.
¿Qué tal? Buenas tardes a todos. Solamente preguntarle al doctor Daniel si considera o qué tipo de pacientes nosotros deberíamos considerar que de entrada son candidatos a hacer una evaluación enfocada. para evaluar un riesgo quirúrgico? ¿Qué tipos de procedimientos o en su práctica, cuáles son los pacientes que él considera de entrada que son candidatos a hacer una evaluación ecográfica enfocada para estimar algún tipo de riesgo? ¿O a qué tipo de pacientes, procedimientos son los que él hace la evaluación?
Perfecto. Sí, Pavel. Daniel, did you understand the question or do you prefer I translate?
No, can you translate it for me?
Yes, thank you. Well, the colleague is questioning about what is the ideal candidate patient for focused cardiac ultrasound. The best candidate previous to the surgery, which is the best patient to perform a focused cardiac ultrasound from the practical point of view.
So I would say the best patient is probably an emergency patient.
Okay.
So someone you don't have any time to look at. And by emergency, it may be someone who's coming in 6 or 8 hours, not necessarily right away, and who you have a specific question to address. So does this patient have severe aortic stenosis? What is the left ventricular ejection fraction of this patient? Those are the sorts of questions that are really easily addressed with care ultrasound.
Ok, perfecto, Daniel. Rodrigo, no sé si quieras hacer alguna otra pregunta. ¿Todavía estás ahí? ¿Quieras hacer algún comentario sobre tu experiencia, Rodrigo?
Nada más, yo creo que dentro de la utilidad, sí tomar en cuenta el uso, que no lo hacemos, realmente no hacemos el uso del volumen gástrico en la parte preoperatoria. Sería importante, en pocos hospitales se hace, pero en los hospitales que hacemos valoración preoperatoria, donde el paciente se cita, se le hace el interrogatorio y se le hace una revisión donde se revisa la placa tórax, el electrocardiograma. Y hay que seguir trabajando en la implementación del uso de ultrasonido para evaluación, y en el cuarto de preparación quirúrgica, en el preoperatorio también debe ser, creo que hoy en día, indispensable tener una herramienta como esta máquina para poder hacer la revisión de la vía aérea, la revisión del pulmón y la revisión del volumen gástrico. Agradecerle mucho al doctor su plática. Creo que su experiencia es sumamente interesante y nos sigue abriendo mucho el panorama para la intervención con el ultrasonido en la medicina perioperatoria. Muchas gracias.
Okay, Rodrigo, gracias a ti. Doctor, well, he is saying about the volume, gastric volume,
Yeah.
because it's very interesting, because we think that in Mexico, we don't use it. We don't use the ultrasound for this specific topic. It's quite interesting, and we think that it is necessary to evaluate our patients, the volume, the gastric volume. Well, there is one more question, Daniel, if you allow me.
Yeah.
Well, Pavel, no sé si quisieras agregar algún otro comentario, si todavía estás ahí, alguna otra pregunta. ¿Sí me escuchas?
No, nada más ya agradecer a todos los que están en el foro, y obviamente agradecer el tiempo al doctor Daniel, que siempre es importante para nosotros que sin ningún interés participen con nosotros. Muy agradecidos por parte de todos los de la asociación.
Así es. Muchas gracias. Dr. Daniel, thank you so much from the Mexican Association. We really appreciate. Thank you for spending part of your weekend with us. We really appreciate it. Thank you for translating your slides, Dr. Daniel. Thank you so much for accepting this conference. It was amazing. Thank you so much. And I don't know if you want to say as the last commentary, Dr. Daniel.
So I would encourage everybody to get involved with point of care ultrasound. I think it's an exciting field, and I think it will really improve how we look after our patients. Thank you, everybody, for attending, and thank you for inviting me. I had a really good time. Thank you very much.
Our pleasure, Daniel. So I'm going to finish the session and the conference, Daniel. Gracias a todos por participar, estamos muy contentos, gracias por acompañarnos. Y pues bueno, les invitamos a seguir participando a todos ustedes en nuestros webinarios que tenemos frecuentemente. De verdad que es una herramienta muy, muy útil en la cual hemos encontrado para transmitir el conocimiento directamente desde los expertos, de todos aquellos expertos en este ámbito a nivel mundial. De verdad, muy contento por participar y nos estaremos viendo pronto. Gracias a todos. Thank you so much once again, Daniel, and see you soon. Thank you for everything.
Thank you very much.
Thank you. See you soon. Bye.
Bye.